Hello everybody, welcome to this webinar organized by the International Hospital Federation. Today we are in the United States with our speaker and invited presenter Kathy Vermoch and Barbara Anderson. Kathleen, good morning. Thanks for accepting this invitation. Barbara, good morning.
Good morning, James.
Okay. Thanks everybody for being with us today in the last webinar we are organizing this year. And since our attendees are ready, I leave you with our presenter. Please, Barbara, go ahead.
Thank you, James. Well, welcome to the University Hospitals and End-of-Life Care Combining Humanity with Efficiency web conference. My name is Barbara Anderson. I'm Senior Vice President for Academic Medical Center Networks and Strategy at UHC and responsible for the University Hospital Special Interest Group of IHF. UHC is an acronym that stands for University Health System Consortium, and as James mentioned, we're based in Chicago. We work with all the leading university hospitals in the United States as well as several international university hospitals to improve clinical and operational performance, advance quality, and improve safety by creating new knowledge, fostering collaboration, and promoting innovation among these hospitals. UHC is the secretariat for the IHF's University Hospital Special Interest Group, and thereby extended our resources and to support this wider global group that participate in IHF. We're delighted to share with you our first benchmarking project of the Special Interest Group on end-of-life care. It was conducted in the summer of 2014, and more than 80 organizations responded, which is evidence of the willingness and desire of university hospitals around the world to learn together, collaborate, and advance the delivery of care for patients and their families. At the end of the presentation today, there will be time for questions and answers by typing questions into the Skype tool. It is now my pleasure to introduce my colleague, Kathy Vermoch. Kathy is UHC's project manager for quality operations and was the lead for this study. She will present the key findings. Kathy?
Thank you, Barbara. Just to go over the learning objectives for this presentation today, we're going to learn about global perspectives on innovative programs and trends in end-of-life care. We're going to review the key findings from a research project that we conducted on behalf of the IHF Special Interest Group for university hospitals and end-of-life care issues. And we're going to talk about also the comparative survey results gathered from cancer centers in the United States and France. Here's the agenda, and Barbara you just heard from, and I'm Kathy Vermoch. The study that we did on end-of-life care was to promote international knowledge exchange among International Hospital Federation member university hospitals because that group felt that this was a topic of great interest to all of us. We wanted to collect baseline information and share the approaches that were currently being used to deliver and manage end-of-life care and to share lessons that we've learned and to recognize opportunities to improve end-of-life care at IHF member university hospitals. An unofficial goal of the study was also to test the feasibility of doing this type of study internationally among university hospitals. Here are the organizations that participated, the countries that participated in the project. And the colors on the map that you see here are the World Health Organization regions, and those were the regions that we used for our data analysis. Here's a little bit more information about those participants. We had 84 university hospitals, and we had to combine the African and Eastern Mediterranean region because we only had 3 total responses. From the Americas, we had 47 responses. From Europe, we had 19 responses, and the countries are listed there. And from the Western Pacific, we had 15 responses. We also had responses from 15 cancer centers, 6 in France and 9 in the United States. So that gave us a total of 99 organizations, and we were thrilled to get 99 organizations to respond to the survey because when we started this, we had no idea. We didn't know what would happen if we got 10 responses. Would that be success? We didn't know. So 99 is great, but I do want to emphasize that in the big wide world, it's still a small number of organizations. And I repeat the ends over and over again, as you'll see in the survey results data, just because we need to interpret some of the data with caution because of those small numbers. However, I do feel that we got a lot of good information, and in some cases we came out with more questions than answers, but opportunities for further study. So we did an online survey of these university hospitals and cancer centers. We asked about their organizational structure and their end-of-life care model and services and funding, and some of their processes, like how patients are referred to end-of-life care, and their team structure and how they do education and training. We also asked about the performance measures they use to assess their programs, and there was a self-assessment exercise included in the survey. They responded about challenges and barriers that they encounter, and they shared innovations and improvements that they've implemented. We received one response per organization, and we asked about current practices in 2014. I'll tell you, coming up with definitions for this project was actually the hardest part. What we found is that there is no standardized definition of palliative, hospice, end-of-life care, that these terms mean different things in different parts of the world, or about the types of services that are always included in these end-of-life care programs. So when we were testing the survey with members of the UHSIG group, I got feedback like, I would answer this question this way for one patient, but I would answer it this way for another. And so we finally came up with a very narrow definition of end-of-life care for purposes of the survey. It's care of terminally ill patients with a life expectancy of 3 months or left and not receiving curative therapies. Now, I know that that does not cover the breadth and depth of the types of work that you do, but we were trying to get comparative data, and so we wanted everybody to think of one specific patient population when they answered the question. We defined EL services as comfort care, counseling, care planning, pain management, palliative hospice care, spiritual care and bereavement counseling, and other services. We also defined the patients as adult recipients of end-of-life care. That is I got a lot of pushback on that as well, because I realized that pediatric palliative and hospice care are really important fields. However, again, for the sake of comparable data, not all university hospitals have a pediatric service. Sometimes they have a separate children's hospital, for instance. So again, to try and get data that was consistent, we limited to adults. Family, individuals closely related to the patient, the team or the professionals that provide the services. And then although we were focusing on end-of-life care in the university hospital, we realized that there's a lot of care that takes place in other settings, and also that there are practices that are common in parts of the world that may not be available in other parts of the world, like, for instance, euthanasia or physician-assisted suicide. So we gave an other response for most questions to get this type of information. So I'm going to go over the key survey findings. And just to mention that when there's differences across the regions, I will display it like this. When it's pretty consistent, I may summarize like all university hospitals, all cancer centers, like that. We asked the organizations, are you a public or a private hospital? And that was pretty straightforward. For instance, in Europe, 84% were public hospitals. In the Americas, 57% were private hospitals. If you look at the French cancer centers, they had a hard time answering this question. And you see we have 67% other. And in reading their comments, it appears that some of these organizations have both public and private components, and that's why it was a difficult question. We also asked, what is your daily census of adult occupied beds? And I'm showing the medians here because we had quite a wide range of responses. But as you can see from these medians, we had some very big organizations respond to the survey. For instance, the median occupied adult beds in the Western Pacific region was 900. The cancer centers were 200 beds or less. but in that range. We also asked, do you have an inpatient end-of-life care or hospice unit? And this varied 30% overall for the university hospitals. Europe was the highest with 42%. The cancer centers in France, 50% responded yes that they do. The U.S. was the lowest for having an inpatient end-of-life or hospice unit. I say America's, there's 40, they said U.S., there was 47 U.S. and 1 Canadian hospital. We asked the organizations to tell us about their model of providing end-of-life services. And this data here is just for the university hospitals, and 58% said they have a centralized team of specially trained staff providing the majority of end-of-life services. Another 10% said they don't have a centralized team, but they do have specially trained staff providing the majority of services. 12% said that most all staff provide end-of-life services, and somewhat worrisome, 20% said there's significant variation in the provision of end-of-life services, so patients are not getting a consistent experience. When we asked the cancer centers this question, in the U.S. cancer centers, they were more likely to have a centralized team. In France, they were more likely to have the specially trained staff. But one thing that really jumped out at me about the cancer centers was that none of them said there was significant variation in the provision of end-of-life services. So one of the things that we did in this project was try to identify opportunities for further study. And, for instance, we might want to talk to these cancer centers and learn what they're doing to standardize their practices and ensure consistency. We asked, what are your top 3 methods of referral to end-of-life services? And it's no surprise that the attending physician, the resident physician, and the nurse are the top methods of referral for both university hospitals and cancer centers. Self-referral was a little higher in the cancer centers, but the thing that really kind of jumped out at me at this list was the automatic referral from clinical criteria or clinical triggers. We hear a lot about clinical triggers, that's a good way to make sure that patients get referred in a timely manner, but not many organizations are using them. So another opportunity for future study might be to talk to some of the organizations that say they are using them and learn what they're doing. We also said, where are your patients most likely to die? What are the top 3 locations where they are most likely to die? And non-critical care hospital units and critical care hospital units were the 2 top places, followed by at home cared for by family and professional end-of-life care staff. This was interesting because we really don't want patients dying in critical care. We would like them in a comfortable end-of-life facility or at home, being cared for in their pain management. Plus, it's really expensive to take care for dying patients in hospital units and in critical care. And you can see that there was quite a bit of difference by the region. In the Americas, 77% are likely to be dying in critical care, as opposed to Europe, 37%. And even in the cancer centers, it's more common in the U.S. than in France to die in critical care units. We asked questions about the services that are being offered, and it was, again, not a surprise that symptom and pain management, family meetings, nutritional counseling, pretty much everybody offers those types of services. Some other services, however, are more commonly available at cancer centers than at university hospitals. For instance, psychosocial assessment and counseling. Now, 86% of the university hospitals said that they routinely offer that service, which is good, that's high, but 100% of the cancer centers said that they did that. As far as non-medical therapies like massage, 80% of the cancer centers offer it, but only 44% of the university hospitals. And some non-traditional type of services like legal counseling were more commonly available in the cancer centers. We also asked questions about funding, and if I had to do it over again, I would have changed the way we asked this question. We were trying to get at the majority of fund where does most of your funding come from? And this was really hard for the U.S. hospitals to answer because funding is so complicated in the U.S. And but we did see that in the European region, 84% of the funding comes from public government sources. In the Western Pacific, 62%. The U.S. funding was all over the place, but 37%, which was the biggest group, said it was private and insurance sources. There's a lot of numbers on this slide, and I just want to take away that I think this illustrates the lack of standardization about end-of-life services available. It's no surprise that the attending physician, the resident physician, and the specialist end-of-life care nurse are common members of the core team. We asked those organizations that said they have either specially trained staff doing the majority of their services or they have a centralized team, and this is their responses. But we did see quite a bit of variation in some of the other areas. For instance, social workers are more likely in the Americas and in the cancer centers. But a psychiatrist or psychologist is most likely to be a core member of the team in Europe and in the French cancer centers. And, a pharmacist is more common in the U.S. cancer centers. A pain specialist is more common in the French cancer centers. And again, a lot of numbers here, but I didn't do this, so I don't know this for sure. But I think if I had surveyed a bunch of emergency departments around the world, I would have gotten a much more consistent list of team members in the ED team than we got here. We also asked those organizations that had centralized teams or specially trained staff, how many staff did they have? And we gave them guidelines for how to count that staff. Staff were majorly devoted to end-of-life care or partially devoted. And as you can see, the cancer centers at above 6% had the highest percentage of staff. The other ones were around 2% or lower. We did normalize this data by we compared it to those adult occupied beds that we collected, and I realize it's a very rough adjustment because we don't know how many patients in those occupied beds actually need end-of-life care, but we were trying to adjust for the size of the organization and make the data comparative. We don't know what is the correct answer. How many staff do you need? Again, another opportunity for study. It feels a little low. 2% or less of your staff providing end-of-life care services, but again, an opportunity for follow-up later. And we asked about the use of volunteers, as you can see here. I mentioned that we had a self-assessment exercise in the study, and what we did was we had 15 ideal statements, and each organization went through and they rated themselves as strongly agree, neutral, disagree, strongly disagree, or not applicable, how they compare to each of those ideal statements. And then we summed up their responses and gave them a total weighted score. The maximum score that you could get would be 1.0. So if this was a test, it would have been like 100%. And as you can see by looking at those mean scores, the organizations rated themselves pretty low across all regions. There's a lot overall, quite a low rating. When you look at the minimums, some organizations were really very hard on themselves when they did the self-assessment. But in each region, there were some organizations that rated themselves pretty strongly. So another opportunity for follow-up might be to go to those organizations that gave themselves a positive self-assessment, see if we can validate those scores, and then learn more about what they're doing. I can't go through the entire self-assessment tool in this presentation, but here are some of the statements that I mentioned that had quite a low level of agreement and lots of opportunities for improvement. So for instance, we said end-of-life services are offered to all most patients in a timely manner. About a third of the university hospitals and cancer centers responded that they agreed. End-of-life services don't vary significantly by patient population, and we use trauma patients and cancer patients as examples. Only a quarter of the university hospitals agreed and a fifth of the cancer centers. We said minority ethnicities are as likely to use end-of-life services as majority ethnicities. It was better in the university hospitals, 52% agreed, could be better still, and about a third of the cancer centers. We said robust processes are in place to assess patient and family satisfaction with end-of-life services. A third to a fifth agreed. End-of-life services are adequately funded by the existing payment system. A fifth to a quarter agreed. The next one is very interesting because at one point we were going to try and find out about the costs of end-of-life care through the survey. But because of the lack of standard definitions and even standard agreement on what is provided by end-of-life services, we decided not to do that. But we said, well, let's see if people actually can evaluate the costs of end-of-life care out of the overall costs of care. And the answer was no, not so much. And as far as it being an organizational priority to control, reduce the use of aggressive therapies near end of life, again, better in the university hospitals, but this is still an opportunity for improvement. We asked a question about guidelines and protocols are in place to support euthanasia and or physician-assisted suicide when it's legally applicable. And for the most of respondents, this was not applicable, but the guidelines were not in place for when it was applicable very frequently. We said to folks, tell us your top 3 challenges or barriers to providing effective end-of-life services. And the top 4 across both the university hospitals and the cancer centers was the communications between clinicians and patients and families, patient and family cultural beliefs about death, entrenched medical staff beliefs about prolonging life, and then lack of funding for end-of-life services. Some of the other things were lack of available staff, etc. It struck me as we looked at the data that we had some contraindications or some disconnects between what people were saying that they were doing and then their actual performance. For instance, when we said staff are offered ongoing education about discussing end-of-life issues with terminally ill patients and families, the majority of the groups responded yes. It could be higher, but still, most of them said yes. However, most of them also said that the biggest challenge or barrier to effective end-of-life care was communication issues between clinicians and patients and families. We said, does required physician training include essential end-of-life care skills? And we gave examples like delivering bad news, having discussions about terminating certain treatments. Again, it could be higher, but the majority said yes, they do require this. But then when we said most physicians can competently provide end-of-life counseling services, responses were very low. Very few organizations agreed that they could. So there's a lot of education going on, but it's not achieving its goals. Don't know what that means. Do we need more education? Do we need different, more practical education? But something's not adding up. We asked, what measures are you using to evaluate your end-of-life care services? And there's a lot of counting going on. People are documenting and counting that they have advanced directives and goals of care in place. They're also looking at the timely provision of care, things like how long after referral did the consultation or the family meeting take place. People are looking at the use of aggressive therapies near end of life, things like surgery, chemotherapy, critical care. People are evaluating the referrals to palliative care and hospice in the last 6 months of life and looking at patients that died with and without palliative care services. Non-trauma deaths in critical care is another measure that was mentioned. And just the utilization of their services such as comfort care order sets. Of course, everybody's interested in length of stay and readmissions, but there were some unique features. They were interested in things like readmissions from hospice. And, of course, satisfaction with end-of-life care services, and this might be staff, it might be patient, it might be family satisfaction. We asked organizations, tell us some improvements or innovations that you've implemented. And we got lots and lots of great innovations mentioned. Here's just a handful. The Liverpool Hospital in Australia, they're trying to standardize the care of dying patients and make sure it happens across the hospitals. So they've got care plans for dying patients, and they've established an EOL coordinator position. At Cedars-Sinai Medical Center in the U.S., they're using the Eastern Cooperative Oncology Group score to screen for appropriateness before administering chemotherapy. The Central Hospital of the University of Liège in Belgium is providing practical training to medical students to help prepare them to address these end-of-life and palliative care situations. The Ottawa Hospital in Canada, they're part of a big regional program. They're trying to enhance access to end-of-life care. They're doing a lot of education, and they're establishing standards. Queen Mary Hospital in Hong Kong, they're focusing on psychosocial care and screening and making sure that the appropriate high-risk patients are referred in a timely manner to social workers and clinical psychologists. The Moffitt Cancer Center in the U.S., they're trying to make sure that patients are referred to chaplains and social workers in a timely manner, and so they have an electronic order that's automatically triggered when the specialist palliative care consultation is ordered. And the Institute of Cancer in Algiers and Nantes in France, they're looking at a couple of different things. Studying criteria stopping specific anti-cancer treatments. They also validated a questionnaire for assessing quality of life for terminally ill patients. So all over the world, people are really working to improve end-of-life care. So what were our conclusions in learning? Opportunities exist to enhance the education of physicians and nurses, to increase the utilization of end-of-life services by selected populations like minorities and trauma patients, to offer some of those non-traditional and non-medical therapies as routine services, to reduce the use of aggressive therapies near end of life, to standardize terminology, measures, and practices, and to network with your international colleagues to help each other improve. Some of our key takeaways. I think we're more alike than we realize. When we started this, I thought, oh, the responses are going to be so different because death is such a cultural issue. But as I read the responses, everybody's struggling this. People are dealing with a lot of the same issues and trying to find good answers. We agree that the major challenges to providing effective end-of-life services are communication issues between clinicians and patients and families, patient and family cultural beliefs about death, medical staff beliefs about prolonging life, and lack of funding. And we concluded that it is feasible to conduct an international study of end-of-life care practices among university hospitals. Some of the project activities, we presented the preliminary results at the IHF Leadership Summit in Korea last November, and we did web conferences for university hospitals and cancer centers in April. We shared the customized end-of-life survey reports with respondents and posted them online in May. So each organization got their own specific responses and also aggregate summary responses for other groups. We presented the final study results to the IHF 39th World Congress in Chicago in October, and we're presenting it today to IHF members by web conference. And we are publishing an article about the study in a special end-of-life care issue of the IHF Journal on World Hospitals and Health Services, and that will come out this month. Some limitations of our study. As I said, no universal definitions exist for palliative hospice, end-of-life, or comfort care, and there's no standardized metrics or data to benchmark services. The study was limited to the care of terminally ill patients near end of life and not receiving curative therapies. The responses are opinions about end-of-life services provided to inpatients by a small convenience sample of university hospitals and cancer centers. And we did not collect the opinions of patients and families, and we couldn't fully explore cultural differences using the survey tool. We also found that there are opportunities to better define what we mean by university hospital, the organization's self-defined, and to improve the survey distribution process, which was a little clumsy. Here is contact information for me and for Barbara if you'd like to learn more about the study or about our organizations. Here are the university hospitals that participated in the study. I couldn't fit them all on one slide, but here are the African, Eastern Mediterranean, European, and Western Pacific regions. Here are the participating hospitals from the Americas. Here are the participating cancer centers. From France, they were members of the Unicancer Group, and in the U.S., they were members of the Consortium of Comprehensive Cancer Centers for Quality Improvement. And I just want to recognize and thank folks from the IHF who supported this whole project, lended their expertise, and helped define and guide it. And also the support of these folks at UHC. It really took a village to get this project done. Here are some references. The information is published on the UHC website, and it's also, I believe, available on the IHF website. So that's the end of the presentation. Should I turn it back to James or to Barbara? I have to stop being a presenter.
James, I believe you were going to open it up for questions. People could type their questions into the tool.
Yes. Okay. So we are going to have 1 or 2 minutes so the attendees can put your questions, and I'm sure that Kathleen will happily give you answers for you. Thanks. Okay. Said that they didn't see in the presentation the participation of the WHO. So the question is there any pronunciation on this end-of-life care?
Participation of who?
The World Health Organization.
On the WHO, World Health Organization.
No. This was IHF, university hospitals, and cancer centers in U.S. and France.
Okay.
Is it possible to unmute the participants and let them just ask questions?
Okay. There is another question.
Okay.
Okay. You mentioned that patients die twice in critical care units in America than in Europe. Does it mean that patients are dying at home in Europe in compared than America?
Okay, we asked the organizations to tell us what were your 3 top places where patients are most likely to die. And so that doesn't add up to 100%. It was what are the top 3 locations where your patients are most likely to die. And across all university hospitals and cancer centers, in either various hospital units or critical care units were the top places. But it was patients were more likely to die in critical care in the Americas than in some of the other regions.
Well, I don't see any more questions. It seems that your presentation was clear enough, Kathleen.
Well, our contact information is included in the presentation, so if someone has follow-up questions, they're free to contact us.
Okay. So we'll remember our...
And also look for the article in the journal, the IHF journal that's coming up.
Yeah, okay. Anyways, we would like to remember the attendees that this webinar, the recording, will be available in the IHF website in about 1 or 2 weeks. And we are going to communicate to everybody the link to for those that haven't been able to attend today the webinar. So you can log anytime and check in the IHF website. Okay, well, we're going to finalize this webinar. I would like to thank you, Kathleen, for your kind and wonderful presentation. Thanks, Barbara, for being present today. And to our attendees, we hope you're going to take part next year when by middle of January we're going to start a new series of webinar. Thank you all for this participation. Thank you again, Kathleen and Barbara. And well, that's all for today. Goodbye.
Thank you.
Okay. Bye, everybody.